we're taking the next step and talking about advancing the clinical care of people with long COVID. And we have numerous guest speakers as a part of this.
Thank you so much. So we had our little mini break. So I'm Jill Cameron. I'm the co-chair of Pillar 2 for the Long COVID Web, and I'm happy to be here this afternoon to support and chair this session, which is advancing the clinical care of people with long COVID. So as we are learning today and over the last 4 years, long COVID is associated with a myriad of symptoms, over 200 looks like. And really the goal of clinical care is to try to meet the people, their needs, and try to address all of these different symptoms. So today we have 4 presentations that we really hope to inform care and really ultimately improve the health and well-being of people who are living with long COVID. I'm not going to give a detailed introduction for all of our speakers. It's all on the Wova app, so please look at that to learn more about their bios. We are also planning to have 4 presentations and then to take questions at the end. So please hold your questions or put them on the Wova app, and we will address them after all the speakers go. So I'm also going to introduce all 4 speakers, and then I'm going to get out of the way and let them run the show. So our first presenter is Dr. Shlomit Rosenberg. She's an assistant professor in the Department of Occupational Science and Occupational Therapy at the University of Toronto. She will share her research that explores the episodic nature of long COVID symptoms and their influence on daily functioning. Second, we're going to have a virtual presentation by Dr. Monica Buss-Morris, who's a professor of applied healthcare research and vice dean of people and culture at the Florence Nightingale Faculty of Nursing in King's College London. She will share the development, evaluation, and real-world implementation of Listen Intervention, a person-centered support program for individuals living with long COVID. Third, we'll have Andrea back in the room, who's the physician lead of the Long COVID Educational Needs Assessment Project and Continuing Medical Education Division at the University of Saskatchewan. Andrea's presentation will explore how the pandemic has impacted the long COVID management, or the long-term management of chronic illness and disability in Canada, drawing on findings from the Disability and COVID-19 Project. And last but not least, we'll have Dr. Kelly O'Brien, who's a professor in the Department of Physical Therapy, the co-director of the Rehabilitation Science Research Network for COVID at the University of Toronto. She will present virtually and share her work that aims to establish a framework for outcome measurement in long COVID research for the clinical practice and research. So I am happy to welcome Shlomit to get us started.
So my name is Shlomit Rosenberg, and I will be presenting. I've got my notes here because I'm always scared that I'll forget what I want to say. I will be talking about a project that was funded by the Rehabilitation Science Research Network for COVID. And the title has changed a little bit since what Jill just presented. I will talk about occupational experiences and how they are related to what people do and COVID symptoms in people with long COVID. And I use this. Okay. So before I start, let me define what occupational experience is. So when occupational therapists, which is what I am, when occupational therapists say occupation, we don't mean work. What we mean is any daily activities that people do that are important to them and meaningful. And occupational experiences are the subjective experiences of engaging in daily activities. So basically how people feel and understand what they do in their day-to-day life. And the core assumption of the OT, occupational therapy profession, is that occupational experiences is actually what supports well-being rather than just what people do or how frequently they do it or how often. So it's about how people feel and experience what they do in everyday life. And our research questions are, first, to what extent do occupational experiences fluctuate among adults with long COVID? So knowing that COVID symptoms fluctuate within days and between days, we wanted to see if occupational experiences would have similar, would show similar patterns. And then we wanted to know, to what extent do positive experiences in everyday life, are they linked to what people do, or are they linked to long COVID symptoms and environmental characteristics that we know that tend to have a connection and impact long COVID symptoms. So what we used, sorry, there's a relatively long introduction, but I hope it's worth it. So what we did is we used an assessment called ecological momentary assessment. So basically people got a text message 5 times a day for 5 days. So that's a lot of effort. And that text message included a survey that asked them first to report, what were you doing right before the prompt, the buzzer went off? They had 30 minutes to respond. And that included some questions about where they were, who they were doing it with, if it was online or in person, those sort of questions. So what were you doing, classify it. And then a few questions about occupational experiences. So what you can see here is 2 types of occupational experiences that have been defined in the literature. So the feeling of productivity and energy restoration. And what people rated is on a scale, a 5-point scale, from a very, very positive, so feeling extremely productive or having a very strong sense of, energy renewal, versus a very negative opposite experience of feeling extremely unproductive or a very strong sense of energy drain. And what we looked at in this study are 6 different occupational experiences that are very often used in characterizing occupational experiences in the literature. And then they were also asked to report their level of comfort with noise, light, temperature, and the amount of movement. And their long COVID symptoms, so physical symptoms, emotional, and cognitive symptoms. Overall, we had 83 participants, and they each completed up to 25 surveys. So overall, we had 1,814 surveys to analyze. So thankfully, there's a biostatistician on the team. And what we're finding, so before I talk about what we're finding, I'll explain how we quantify the idea of fluctuation. So we use something called a lability metric. So basically, if you look at these, this is an example of 2 people and how they rated energy restoration or drain across the 5 days and the 25 assessments. So you can see in the Mr. Blue here on top, basically for most of the surveys rated neither. So neither restored nor drained, and a little bit of fluctuation. Sometimes they did feel restored. Some activities did feel like they were draining their energy. Versus Mr. Green on the bottom, that we can see very significant fluctuation. So across one day, if you look at day 2, they reported for one activity that it was extremely draining, and another one was extremely restoring or restorative of energy. And what we look at is the differences between subsequent reporting of the different experiences. And this translates, and I won't get into the math, pretty much understand it, but I won't get into it. But this translates to a number, a metric, and higher reflects more fluctuation or more lability. And what we see here, so at the calculation is for the Mr. Blue, we get a relatively low, so stable reporting versus the green, which is high. And now, so across all our sample, what we found is this. So this is the mean lability metric for each occupational experience across the full sample of 83 people. And so what we're seeing here is that energy restoration was the highest, and I organized them by order. So there was more fluctuation in energy restoration than all the other experiences, which is not surprising, knowing that fatigue and energy are significant issues for people with long COVID, and that competence would have been on the other end of fluctuation. So that was relatively stable and kind of close to low lability metric. And then we wanted to understand to what extent did the activity. So what people do, to what extent did that predict their experience? And what we did here, we did a fixed effects regression model. So basically, it looks at, for each person, how their rating of an experience changes on a survey where they did a specific activity versus all other surveys. And what we found is, if you look at all the 6 experiences, what people do explained between 18 and 28% of the differences between people in the experiences that they have. So the explained variance. And in terms of in psychology or behavioral research, that level is quite meaningful, significant. We don't expect any one factor to explain 100% of the variance, because there are personal issues or circumstantial factors that may also impact the experience. So that's finding number 1. Now, our next question was, to what extent did environmental conditions and the self-reported long COVID symptoms in the moment predict positive experiences? So the advantage of EMA is that it allows us to capture how people felt. You're not reporting 2 weeks, how people felt over the last 2 weeks, but it's in the moment. And to my surprise, I will say, the environmental conditions in the moment did not predict any more than the activities already predicted. So they did not predict the experiences beyond what people do predicted. I'm not sure how to make sense of that. My hypothesis was not that. So I'm still trying to make sense of that, and I'm happy to get any opinions and thoughts on why this happened, or why this finding is what we found. And I'd like to use the last few minutes to dive a little deeper into a few findings about the relationship that we did find between what people do and the experiences that they have. So what we've got here is a model that shows, the numbers here are the coefficients, and I only presented the ones, sorry, I'll take a sip of water. I'm hot. So I only presented the ones that were statistically significant. So wherever there's a line, that means that the relationship was not statistically significant. And what we're seeing here, so for example, if we look at the top line for working is significantly associated with a higher feeling of productivity, feeling more competent, and feeling more socially connected. It is also associated with feeling a higher level of energy drain, so lower energy. And then in comparison to that, if you look at having fun and enriching or learning activities, and these are classifications that the participants chose, it's not what we decided that they are. So we see that these activities are associated with higher levels of pleasure, more interest, feeling more competent, and feeling more socially connected or more productive. So that's and they are not associated. So while having fun, whatever that means, if they were partying or I don't know, sitting down and looking at the view, or learning, they are effortful or could be effortful, and yet they were not associated with energy drain. So that's one thing that I want to highlight. And then another thing that I want to highlight that I thought was very interesting is activities that participants classified as relaxing or resting. And that could be anything, whatever people define. It could be watching television, it could be knitting, it could be listening to music. They were associated with higher levels of energy restoration. That's one thing to notice. And they were also associated with more pleasure and interest, while also being associated with feeling unproductive and more socially isolated, so on the negative. But activities classified as doing nothing, which I imagine as crashing on the couch despite having planned something else. So it's not a decision to sit down and relax, but it's kind of I got to a level of energy that I just can't move. Those were negatively associated with all the experiences. So they were displeasurable, They were associated with disinterest, with feeling unproductive, incompetent, and socially isolated. So I think, I thought that was very interesting. And if I think of what all this means, so putting aside the lack of a meaningful or statistically meaningful association with environmental factors and symptoms, which we'll keep looking at or thinking about, what we can take from this is that as occupational therapists, but not only, other health professions, supporting positive experiences through social activities, learning, spirituality, which I didn't mention as a separate finding, and fun are very important. So encouraging people to find routines that incorporate those sort of activities is extremely important for positive occupational experiences that support well-being. And helping people through distinguishing between or not getting to the point of I'm crashing and doing nothing, but managing their routines in a way that carve out time for purposeful, relaxing activities is also a way in which we can support people in maintaining better well-being and better occupational experiences. Thank you. Oh, sorry, I do have a
Shlomi,
I do have a
very
thank you
much.
here. And I forgot, I'm sorry, on the very first slide to give a shout out to Susie Golden, who's here. It was also a member of my team. Thank you, Susie. And I'm sorry, I forgot to mention in the beginning. Thanks.
Thank you very much, Shlomi. That was great. It is hard to speak in these masks.
Yeah,
I find all of
I'm
a sudden
sorry.
I can't breathe. We're going to save questions to the end. Thank you. So we're going to go virtually now for Monica's presentation. So I'm going to let the powers that be bring her up for us.
Yeah, okay, brilliant. Thank you. So I'm going to talk today about the LISTEN trial. This was a trial of a long COVID personalized self-management support intervention. And it was funded by the National Institute for Health and Care Research and UKRI in the UK. And so just to start off with really acknowledging all our partners, we had partners from across the UK in delivering this project. So where did we start? So this work started out, we were funded in July 2021, and it was really at a time when long COVID was new, it was misunderstood, and myself and Fiona Jones, who were the co-chief investigators, we really nobody really knew where to start. So what we did was and our aim was to co-design a personalized self-management support intervention, and it was building on the Bridges self-management concept. So we ran this co-design program, and then we were funded to continue with the full trial evaluation. So what we wanted to do was really reframe personalized self-management support in the context of the complexity and the variability of the long COVID symptoms, really that now is far more accepted. And that meant placing the narratives, experiences and concerns central to the intervention, so that the people who were living with this, we were drawing on their learnings and their collective experiences. And we designed this intervention together with people with long COVID, and then we went on to evaluate it in a fully powered randomized controlled trial within 554 people. So what did we do and who was involved? Well, our early co-design group involved 28 people living with long COVID and 9 healthcare professionals with experience supporting people with long COVID. And you can see them in the bottom left-hand side of our slide here. There was a 5-stage process. We had we hosted small co-design meetings with subgroups of this larger group. We then brought people together in a larger group. And those two groups initially were first people living with long COVID and health professionals separately, and then we brought them together We also interviewed people one-to-one and edited those interviews to build resources and to help capture their stories. So what were the principles of the intervention? Well, the interventions were delivered by healthcare practitioners. So they could have been nurses, physiotherapists, occupational therapists, psychologists. And we were asking them to follow the 8 key principles of the listen intervention. And that was around attentive listening, listening beyond words, and really being curious about what they were hearing, encouraging reflection, helping to people who were living with the challenges of the fluctuating symptoms, to explore their hopes, their dreams, looking for moments of joy and feelings of control, and really encouraging health practitioners to reflect upon their choice of language as well, which was, I think, it was a real problem really starting out, that people weren't feeling believed. Alongside the intervention with the practitioners, there was a book, and the book had 6 sections, and that book was posted out to everybody who enrolled in the trial. And it covered stories, it covered the stories that we'd collected in the co-design. It shared some of the symptoms, the challenges, but really importantly, the solutions and other people's solutions in managing their journey, and encouraged people to reflect and plan. And that book was then used during up to 6 one-to-one sessions with the trained practitioners. So in terms of the trial, we enrolled anybody over the age of 18 who had had symptoms for over 12 weeks, but critically were not hospitalized for the acute COVID infection. We randomized 554 people, and people were either allocated to receive usual National Health Service care, which is the care that was received in the UK at the time, which could have been relatively variable, or to receive this listen intervention, which were the 6 sessions and the book. And we had a 12-week follow-up point, where we had 200 who completed the follow-up in the usual care group, and we had 210 in the trial group. So what did we find? So our primary outcome was a measure of activities of daily living, where lower scores were better. And we found that people who received the listen intervention were more able to engage in activities of daily living that mattered for them. And crucially, when we accounted for the baseline values, the age, gender, ethnicity, employment, and also the number of long COVID symptoms at baseline, then that difference was statistically significant. We also found changes in emotional well-being. The people who received the listen intervention reported improvements in feelings of emotional well-being. And again, those in the listen group scored nearly 6 points less than those in usual care. And people, in terms of fatigue, people who received the listen intervention reported that the fatigue had less impact on their daily lives. And this was across the 3 domains of the fatigue impact scale, where the lower scores were better. And again, we had an adjusted effect estimate of nearly 9 points. So people were scored nearly 9 points lower if they'd received the listen intervention. In terms of health-related quality of life and the mental health component, we had similar findings, where people who received the listen intervention reported better mental health-related quality of life. And that was with the SF-12, the short form 12 mental health component score. And then what was really important for us was that actually the theory that we were trying to test was that people would, through being supported in a personalized way, have greater feelings of symptom control. And we assessed that using the generalized self-efficacy scale. And we found, again, that people who received the listen intervention felt that they were better able to control their symptoms, in terms of they were more confident to be able to do that. So what about value for money to people with long COVID in terms of society? Well, what we were providing was different to what usual care was in the NHS. In the NHS, people either had nothing, or they had group-based therapies or group-based sessions, or they were given information. Our up to six sessions were one-to-one. So the actual cost of that intervention, in some cases, was greater than if people had had usual care. But what we found was that that was dominating usual care because people who received that intervention were more likely to engage in their usual daily activities. They missed fewer work days and they reported lower healthcare expenses. Okay, so now in 2025, what did we do? Well, we integrated self-management evidence, and that was the evidence from Bridges self-management with the lived experience of people with long COVID. And we provided support when not many people could access that kind of personalized support. And we created through this intervention a unique space for people to be supported to do what mattered most to them. And we showed the value of health professionals that were trained to listen and to validate and to help with problem solving and self-management strategies. And by doing that, we were able to influence self-efficacy, so confidence to manage symptoms, and also to improve emotional well-being and quality of life. So thank you very much.
Thank you very much, Monica. We're going to move on to Andrea. You're up next.
Thank you so much. Hi, everyone. My name is Andrea Vasquez. I'm a family physician. I work in Regina, Saskatchewan, and I work with the University of Saskatchewan. I'm going to present today knowledge mobilization, a way to support individuals suffering from post-COVID-19 condition or long COVID. And I think it's a perfect moment after we have all talked about what the research have been and how we can actually move that knowledge into everyone, which is very important. So one disclosures is we get a grant from the Cochrane Canada McMaster Grade Centers with financial support from the Public Health Agency of Canada. That was to help us do and have some educational resources and actually forward dissemination of the Canadian guidelines for post-COVID condition. We also have participated in the long COVID working group with Saskatchewan Health Authority. The Canadian guidelines was part of two of the groups of those guidelines as well, and also assisted with the final report in 2021 and the PCC self-management resources. We'll talk about that a little bit. So as we all know, definitely COVID has actually taken a huge toll around the world, not to say in Canada, of course, and how many people have now suffered from post-COVID condition, and we have repeated it over and over today. We can see how it has impacted people. So we know that 2/3 of Canadian adults reported at least one confirmed or suspected COVID-19 infection, and that more than 1 million people are still experiencing those symptoms and that have not improved over time. So what the impact is, from patients and individuals who are suffering from post-COVID conditions, 74.1% are missing 1 or more days from work or school because of those symptoms. The number of days missed have been around 20, more or less, also for missing work and school, and that's the minimum. We also know that 58% of adults in Canada who had longer-term symptoms continue to have them, and that 66% of adults who sought healthcare services reported not receiving any treatment, services, or support for any of the longer-term symptoms. That's huge because we need that, and we have been saying over and over in this conference, please, what can you do about that? So we know that after the pandemic, after all this happened, people have returned to their lives. You just continue busy here and there, and this is how things are for many people. But we forget that people still suffering from these symptoms. We see here in this quote, the sense of abandonment, the sense of frustration, and the need and cry for help. This is a quote from one of the patients I'm going to talk in a moment, who participated in focus groups interviews that we did in 2024 through the continuing medical education and educational programming that we developed. So what can we do to help individuals suffering from post-COVID-19 condition and those caring for them? There are many things, but in this case, I want to keep to the attention of, with all this publishing literature, so much information, we don't have much time. And even here, we can see that more than 5,200 articles have been published, and even more now, probably, that we're talking in PubMed. We don't have time to read through them. We don't have time to identify what can I use and what can I not use. So with all this, the burden in patients, in healthcare providers, and with the literature, we decided, okay, you know what? We're going to focus on one of the three main pillars that a working group in Saskatchewan, we got together clinicians, patients suffering from post-COVID condition, and three of pillars were the clinical pathway, research, and education. I was part, and as the lead, physician lead for the education aspect with the continuing medical education with the University of Saskatchewan. So the first thing that we do was creating an initial learning needs assessment. We know that that is important in order to identify where are we at this point with the knowledge and what's the gap in order to being able to go to where the ideal state of knowledge will be. And then when we identify that gap from the people who need that knowledge, we're able to create educational resources to being able to deliver this and support people by disseminating this knowledge. So the first thing we do 2022, 2023 was a survey that we sent across Saskatchewan, across the province. So we have patients, families, healthcare professionals, as well as department heads participating in this survey. And that gives us an idea of what were those areas and topics that were important for people to know, and also how and what methods they wanted us to use to deliver this information. We also did from there were focus group interviews that we were able to do for those who participated and agree to participate in the focus group interviews. So from that, individuals suffering from PCC perspectives, the challenges were lack of knowledge, validation, education about PCC, accessing clinical resources, and these were priorities that they identify: knowledge and validating post-COVID condition, addressing the symptoms, and management complications. So we can see here in these two quotes from patients who participated, where individuals suffering from PCC, again, the lack of information and the need and cry for help. The next group were healthcare providers also participating in those focus groups. These were the main priorities identified, so accessible resources, user-friendly resources for patients and healthcare providers alike, use of multidisciplinary teams, presence of detailed guidelines to make timely and accurate diagnosis, patient education on symptomatology, and validating the symptoms. And again, we have been listening to that. The validation of symptoms is a very important aspect. So here we see a quote from one of the healthcare providers who participated in the focus groups, exactly that. We need help as healthcare providers to get information, to help our patients, to navigate the system and see what resources are there to help our patients. So after that, along with the CAMP PCC guidelines that were in development at the time, and we already talked about those, we developed different infographics, webinars, outreach visits, online resources that are available there. We have put in all your tables some of those infographics and resources that we have been developing along with many, and I'm going to talk about that, who to thank for, but these help us to develop also educational programming through the continuing medical education at the university. So we evaluated all this dissemination, the way that we did the webinars at the end of those, in order to know, okay, what is the impact that this is having at the end of the day, right? Changing and helping patients by changing our behavior. So we use the RE-AIM framework in order to evaluate this process. So reach, effectiveness, adoption, implementation, and maintenance. So we collected data right after the actual webinars, a month follow-up, and then 3 months follow-up. We can see here the number of respondents from that. And we know as we go along, less respondents, but we still have very useful data from that. So here we see in the reach, sorry for that change, but so basically you see how many registrations there were people from all across 10 provinces in Canada. We see here on the right side how many people actually were able to view these videos, because those webinars were recorded, they still posted. You can see them in YouTube and in the online resource that we have from the University of Saskatchewan, and also through the Canadian PCC guidelines. We also have here, we also reach out to people using social media, and those were responses as well, downloads and whatnot from the beginning of the year. And that told us that people was interested and was looking at those resources. And then we also have the adoption and the implementation. So after 1 month follow-up from these webinars, we can see how often people are using those resources. And further than that, we also have different other groups of people, healthcare providers actually having their practice, and that they can also be affected in a positive way by educating physicians, healthcare providers in general, to deliver this to our patients. So what are the next steps that we have from here? So there are a few things we're still working on. And the first one is more resources for education and knowledge mobilization. So we continue to work with the continuing medical education. We have another series of webinars coming up now in the winter. So welcome everyone to disseminate these and participate. There are different specialists across the province that actually have been helping us to deliver these webinars. Education programming is part of that. Outreach visits, we already have plenty of those. Online resources that you have in our website, and grant application opportunities. We also have translated some of those infographics into 10 different languages because we understand that not everyone may understand well English and French. So all the webinars are in English with subtitles in French. And we have, as mentioned, translated that. We also are in the process of translating part of the online resource into Spanish. I was just recently in the WONCA, the World Organization of Family Doctors, presented this work and talk about, and there is a amount of people that don't know about this. They don't know where to look for help. So we decided to translate this in Spanish. I speak Spanish, my first language, so it was actually easier to do that. And we're going to plan also webinars in Spanish for people who doesn't speak English or French. That is a lot. And they also are in the same boat as we are here in Canada and North America. We also had a grant approved already through the Saskatchewan Health Research Foundation. That is the Mobilize grant. It's basically to mobilize this information and the resources that we have to make it available across. This is specific for Saskatchewan, but definitely these events will help us also to disseminate across Canada and beyond. And then we have applied already for another grant, which is through the Saskatchewan Health Research Foundation, specifically looking at enhancing neurocognitive and mental health care for post-COVID-19 condition, resources that we are looking into creating, and we are partnership with the School of Rehabilitation Science because we think that it's important to get together, and that will make us stronger to being able to move forward with this mobilization of knowledge. So those are things that we are working to currently together. So when I acknowledge all the co-authors for all this work, we want a special thank you for all the participants, the University of Saskatchewan, the Continuing Medical Education, the Department, Saskatchewan Health Authority, Public Health Agency of Canada, and all the people and the support that we have received and that we continue to be able to move forward with all this work. So I want to invite you, this is a QR code that takes you to the online resources. And if we click here, it will actually take us, and you can see all the resources, the links to the Canadian PCC guidelines, the links to all the different self-management report resources, all the infographics I left, as I mentioned to you. Different ones that have also the link, and you can distribute as well. You can download it from here. And one of the things that we also really quick did was a quick reference guide that specifically we developed that, but it has all the different resources in the back that people can access. Those resources are just existing that we put all together to make it easier for actually people, healthcare providers, and patients to navigate through what is existing, not just in Saskatchewan, but across Canada. So I want to invite you to please disseminate these resources and let people know that they exist and they can use them. Excellent. Thank you so much.
Thank you very much, Andrea. Wonderful. We'll take questions at the end, and we're going to go back online for Kelly O'Brien.
Okay, can everybody here see the screen and hear me okay? Great. So it's my pleasure to present today on behalf of the Measurement and Assessment Paradigm for Long COVID, otherwise known as MAP-LC, updates from a scoping review of outcome measurement. And I the QR code here is the protocol that has just been published for the scoping review for those of you who would like more information on this project and some of the updates today. So this project has been a massive undertaking with thanks to the funding from Long COVID Web as a foundational Pillar 2 project. The team involves over 40 members representing 10 networks and is international in scope. And many of you who are online today and in the room have been instrumental to this collaborative work. So thank you. And I'd like to actually give particular mention to 3 individuals who have been instrumental to MapLC, and that is Anne Barrere, who is the co-lead of the project, Kira McDuff, lead coordinator, and Julia Nathanson, research coordinator, who have been critical to bringing the project to this stage and in helping to prepare today's presentation as well. So in terms of some background and context, we know that outcome measures are used to describe health outcomes. They can predict future events. They can assess the effectiveness of different interventions or evaluate changes in people living with long COVID over time. But an outcome measures is an umbrella term that can be used to characterize patient-reported outcome measures, such as questionnaires, patient-reported experience measures, as well as performance-based outcome measures, such as the 6-minute walk test, for example. However, there are distinct issues of measurement that require particular attention in the context of long COVID. And we see that there are an increasing number of outcome measures that are being developed, sometimes made to be long COVID specific in nature, but those measurement properties, meaning their validity and reliability, may be more unclear. So a coordinated approach for helping to guide outcome measurement in clinical practice and research is needed. So the overall aim of MapLC is to establish a framework of measurement for adults, children, and adolescents and caregivers for use in long COVID research and clinical practice. Our research question specifically is, what is known about outcome measures to describe, evaluate, or predict health outcomes among adults and children living with long COVID and their caregivers? And the concepts that we're particularly interested in are not only what are the outcome measures that are being used or exist, but what are the purpose of measurement? What are the constructs in which those measures are being used to assess? And what are the measurement properties of those tools when known? We're interested in the context and the population in which these outcome measures are being used and considerations for implementation, particularly given the patient population. So we are undertaking a scoping review using the Art Skin O'Malley framework and Joanna Briggs Institute, and we're embedding both an evidence review with the consultation phase throughout. And we have completed the first 3 steps of the evidence review, and we are at the stage of charting the data or data extraction, and that's where I'm going to focus today's presentation on this step. For step 6, which was the consultation phase 1 that was conducted last year in the environmental scan, I welcome everyone to see poster 17 with McDuff and Alf to learn more about those findings from the environmental scan. So we developed a search strategy in consultation with an information specialist and searched databases including Medline, Embase, CINAHL, PsycInfo, and Scopus. Up to March 2024, we were looking for articles that included adults or children living with long COVID or their caregivers, and included outcome measures that could be patient-reported outcome measures, performance-based outcome measures, or patient-reported experience measures. We were interested in articles of any study design in research or clinical settings in English or French published in 2020 and beyond. This Prisma flow diagram gives an outline of where things are at with respect to the evidence review and inclusion of articles to date. So there were just over 13,000 citations that were imported for screening into Covidence. Just over 6,200 articles were screened for abstracts. and most of those were excluded, which left just over 1,000 articles that went to full text review for inclusion. And the articles that tended not to meet inclusion at this stage were not inclusive of our population of interest, so persons living with long COVID or their caregivers, or did not include a relevant outcome measure. So this left 802 articles that went forward for data extraction. And this is where we're at today. As of today, actually 79% of the articles have been completed for data extraction, with just 164 remaining. So I'm going to spend the remainder of the talk to share a few reflections and preliminary takeaways that has come up during this process. So the first is, obviously, we know there's an explosion of literature with a large volume of citations and articles, and the variability in terminology and definition poses great challenges when trying to ascertain whether or not the target population is actually individuals living with long COVID within the literature. It was difficult to ascertain also if authors use an actual outcome measure in some of these articles, or whether they were referring to a questionnaire that was developed particularly for this given study. So, for example, a symptom questionnaire that was developed for this a particular study as a one-off. And this was particularly difficult to determine at the stage of a title and abstract review. Many articles do not clarify the mode of administration, particularly for patient-reported outcome measures. So it's sometimes unclear whether those measures are administered remotely or in person. And we know that there are several long COVID-specific outcome measures that are continuing to emerge. And so there will be updates to do as this is an iterative process with this review with respect to the framework. And then also, there were limited articles found with children, young people, or caregivers. So this leaves us with some complexities, challenges, and considerations. And I feel like we're at this tip of the iceberg. And some of these bullets here are gleaned from points that Anne Barrere authored in a commentary, which is currently under review with Health and Quality of Life Outcomes. So I'm going to share some of the highlights with you today. So the study design and a lot of the evidence that we've seen is very cross-sectional in nature. So these study designs really help to take a snapshot of characterizing symptoms of long COVID, but they're very what they lack is the ability to consider that episodic or fluctuating nature in symptoms that may occur over time and captured in a longitudinal study design. The constructs that we see measured in the literature are often the ones that may be more important, that we've heard as being very important to the community, such as the ability to work or post-exertional malaise. These may not be the constructs that are primarily captured within the literature. And it's good for us to remind ourselves that just because something's been unreported in the literature doesn't mean that that particular challenge is absent. The purpose of measurement has been a really important takeaway, and we've seen that outcome measures, in particular ones to screen for symptoms of mental health conditions, have also been used to draw conclusions about the prevalence of mental health conditions in the population of persons living with long COVID. And this is often done without correlation or use of a clinical assessment. So some cautions there in terms of interpretation. And then very few some of the literature, it's uncommon for authors to describe the duration of their assessments or the accommodations or strategies that were put in place to accommodate for fluctuations in energy capacity, particularly when there are numerous forms of outcome measures that were administered. So in terms of our next steps, it's completing the data extraction and then moving on to the analytical stage of collating and summarizing the results and essentially drafting this preliminary framework of measurement that will then be taken to the next phase of consultation with the team to refine and develop an online menu of outcome measures with highlights around their measurement properties for use in clinical practice and research, highlighting the need that we are going to be able to need to go back to the literature for that updated search, particularly looking for some of the outcome measures that have emerged since 2024, and also have documented evidence on their measurement properties. So for more information, please see poster 17 on the results from the preliminary environmental scan from MAPLC. And this was a web-based survey of experiences and familiarity with outcome measures for people living with long COVID and their caregivers. And stay tuned for Anne's commentary, which hopefully will be published in the near future. And here's the QR code here as well, if those are interested, for anyone interested on the full protocol. So thanks again to the funding and acknowledgement support from Long COVID Web, as well as many of the members of the team who've been instrumental in seeing this project to fruition and implementation. So thank you.
Thank you very much, Kelly, Andrea, Monica, and Shlomit for those wonderful presentations and for the great research that you're doing. And now we're welcoming questions from the audience as well as from online. Do we have any online questions back there, Susan?
Yes, we do, actually several, but I'll try one at a time. I just wanted to preface with a comment. Long COVID Web has tried to put together lists of trusted resources, and we've just heard about some terrific resources here. And actually, we've had a lot of support from our very engaged patient advisory committee and other patients to help populate that list. If there are resources that we can help you disseminate, please let us know. We will do our best to incorporate them in a sensible way that doesn't overwhelm people as well. So thank you for that. There's a few questions around the huge gap in healthcare professional education and also public education. So I just wonder if there's any comments or thoughts on what we can do better. Can we mandate it? Are there sort of carrots and sticks that can be employed or deployed to fill that knowledge gap and change the culture, really? Thanks.
Yes. So I will take that question. So definitely I agree that, you know, we all agree that there is a lack of knowledge. First of all, is a new condition. We all had in our curriculums, you know, when we studied, this was not part of it. So we're now learning something new and we have to get used to it. A lot of people and a lot of healthcare professionals are not, they don't know how to help the patient because they don't even know that long COVID is something that exists to start with. Not because they don't want to believe, but they don't know, they don't have the knowledge about it. So that's the first thing I think is make sure and by conferences like that and start to spread the word. That's what we want to do is spread that education material to people across Canada, across North America, Latin, like everywhere that it can go because we need that. See, it's about validating that this is something that exists. I think this is the first thing that we need to do. And with that, providing those educational materials that people can go there when they have time. We sometimes don't even have time to have a break in our day-to-day lives, right? So having that and having the opportunity to connect, go and look in your own time and being able to look through those resources will be important. Make it a mandate is something that I feel it'll go now with the healthcare system and all of those that are actually in higher positions. So if we, through the research, can demonstrate with numbers, with results, that this is in fact something that is true and it exists, that will something, I think that's the way we will get there, not just going and ask because if they don't see the numbers, it's the same as we were talking. Normal resource doesn't mean that the normal results doesn't mean the patient is completely fine. So by demonstrating that this is an ongoing issue. So that's, I think it's disseminating, validating, spread the word about that existence, and then move forward with the research and what we're doing to get resource and move forward, yeah.
Great, thanks for that. I've just been given the 5-minute warning. So Adam, go ahead and ask your question.
This is on? Yeah. Hi there. Thank you all for speaking and sharing knowledge as you have. My question is more particularly for Monica. I don't know how familiar you are with the Canadian public health system, but if you have any familiarity, could you outline, I guess, in your opinion, what are the major differences between how the NHS is dealing with long COVID and how the Canadian public health system has approached it?
Well, oh, that's quite tricky because I've only ever been to Canada once. and it was for like 5 days in Vancouver. So I don't think I can do a comparison, but what I can tell you is what's going on in the UK and the NHS, and then maybe you can, make your conclusions as to what might be different. So when in the very early stages of the pandemic, what we saw were specialist long COVID clinics that were established. They were regional, and it was like patchy in some places, because in certain places, like where I was living, there was only one clinic, and you had to wait a long time to get there. You were referred by your general practitioner. What has happened more recently is that the long COVID clinics themselves have been, I wouldn't say decommissioned, but they've been brought together with other post-infection groups and other long-term condition management interventions. So it's much more around a more generalized approach to post-infection condition management that we're seeing, and we're seeing a big shift to integrated neighborhoods and care in the community. With lots of different group-based interventions to support that.
Thank you very much.
Great. Is there any other questions? Susan?
Yes, it's a question just to see if anyone is aware of the use of alternative therapies or medicines in the treatment or care or self-management of long COVID.
We'll open that up to all the speakers to share anything that they know about alternative treatments, or maybe people in the room have some experience.
I think that there is not a specific research about the use and kind of literature that can support that. Obviously, there will be different experiences from people individually, maybe that they have found that may be beneficial, may not. So, but I don't think, I was actually looking through that and the guidelines, there's nothing specific about that. But again, as many other therapies, there may be differences between the experience from person to person. So at this point, I don't think there is a specific research about that. That's all I can.
So Shlomit, I'll put you on the spot, because I'm just wondering, because you asked people what types of activities they did, and then you had some activities that were really energy regenerating. And I wonder if you can think about any types of activities that people spoke about that may not be considered sort of mainstream medicine maybe. And there's a microphone there for you. Sorry. Yeah.
Does it work? Yeah. Okay. Yeah. So there was a slide on that, which I cut out because I didn't have enough time. So specifically, activities that were found to be associated with energy restoration included caring for myself. So that would include anything. Could be a hot bath. It could be anything. Maybe, again, people interpreted this in different ways. There was the activity of relaxing, but what I found specifically interesting was the category of experiencing spirituality. So the idea of experiencing, people reported that experiencing spirituality was associated with energy restoration. And experiencing spirituality is highly individualized. It does not necessarily have to be religious. People report experiencing spirituality through connection to nature, to art, to music, and religion. Whether it be more formal religious practices or informal ones. So that would be one way. It's not alternative medicine, but it is an important aspect of energy restoration.
Thank you. I've been given the 1 minute warning, but we have somebody at the mic, so we'll take one more
I can be less than
Yeah,
10 seconds. My name's Leslie Story, and I'm a long COVID advocate, but I'm also a former professional athlete who was disabled by long COVID. And so I'm doing a lot of consulting with some of my former high profile clients and some sports medicine clinics about the role of movement in therapeutic rehabilitation for people with long COVID. So there's lots of really interesting data. If anybody wants to pick my brain, I'm happy to answer any questions.
I think we are supposed to wrap. Maxie, can I take one more? What do you want me to do? One more. This person's visiting from the Netherlands. We'll let her speak. Go ahead.
Wow, thank you. I wanted to share a little bit of an observation we had in the Netherlands because we had a patient organization, a day where lots of patients visited us. And with the stand that we organized, we actually asked patients, can you write down on a note what helped you? And then alternative medicine came up a lot. So it's not scientifically researched, but it was a form of getting in input. So I wanted to share that. Thank you.
Thank you very much.
If you don't mind, I want to just make one
Okay,
more
go ahead.
comment. Really quick, it's just to clarify the use, there is a self-care resource online in the Saskatchewan Health Authority that was mentioned earlier. I wanted to clarify that it is not the resource itself, but that was creating harm to people. It was the way it was used because basically some patients were just given this, go and read, and that was it. But that's not the way you do it. You have to support your patient to go through questions to see how they are along going with this resource. So I encourage actually the people to use it. It's there. I know that they have been, so it's not that the resource itself was bad, it's the way, again, was used. So by going with your patients and helping them to go through that and navigate is a different way to approach it, and it will be beneficial. That's all.
Thank you very much. I think that's a wrap for us. So I don't know if it's a wrap for the day, but thanks for your interest in the clinical research and thanks to our wonderful presenters.